In this era of primary angioplasty, it is important to recognize the infarct-related coronary artery from the ECG prior to cardiac catheterization. During primary angioplasty, usually first the angiogram of the non-infarct-related coronary artery is taken using a diagnostic catheter. Then a guide catheter is introduced into the infarct-related coronary artery and a few diagnostic shots taken, soon to be followed by primary angioplasty. This is to ensure reperfusion of the infarct-related artery at the earliest. In anterior wall myocardial infarction, it is the left anterior descending coronary artery which is occluded, and maximum ST segment elevation is noted usually in lead V2, with lesser degrees of ST elevation in adjacent leads. If it is a more distal occlusion of the LAD, ST elevation can be noted in leads V2 to V6 and sometimes in inferior leads. This is because a type 3 LAD wraps around the apex of the left ventricle and supplies the inferior wall. In this case, though ECG shows a seemingly more extensive infarction involving inferior and anterior walls, it is actually a smaller area of infarction sparing the proximal interventricular septum. Inferior wall infarction is usually due to occlusion of the right coronary artery. If it is associated with ST elevation in right chest leads, V3R, V4R, it is due to right ventricular infarction and indicates a more proximal occlusion of RCA, as right ventricular branches originate from proximal portion of the RCA. Inferior wall infarction could also be due to occlusion of a dominant left circumflex coronary artery. In that case, it is usually associated with posterior and lateral wall infarction. ST elevation is noted in inferior 2-3 AVF and lateral leads 1 AVL, V5, V6. Posterior wall infarction is identified by tall R waves in V1, V2 along with mild ST depression and upright T waves, mirror images of Q, ST elevation and T inversion. In inferior wall infarction due to RCA occlusion, ST elevation is maximum in lead 3, while in LCX occlusion, it is maximum in lead 2. In left main coronary artery disease, there is usually ST segment elevation in AVR with ST segment depression in a large number of other leads. Similar pattern can also occur in severe proximal multivessel coronary artery disease. Lead AVR is often neglected during the analysis of ECG tracings, but the importance of scrutinizing AVR in the setting of acute coronary syndrome cannot be overemphasized. ECG in a person with persistent anginal pain for the past several hours showing ST segment depression in anterolateral leads along with sinus tachycardia. ST segment elevation is noted in AVR. Mild ST depression is seen in leads 2 and AVF. Such a pattern is consistent with significant left main coronary artery stenosis. Clinical evaluation and X-ray chest showed features of pulmonary edema. Angiography done after initial stabilization with intensive medical management showed severe stenosis of distal left main coronary artery along with multiple lesions in all the 3 vessels, making a standard indication for an urgent coronary artery bypass grafting. A similar ECG pattern can also occur in severe proximal triple vessel disease. The previous ECG is given below for comparison, which shows minimal changes. But the ST segment elevation, minimal in AVR, is seen. This highlights the need for serial ECGs in acute coronary syndrome, as initial ECGs may be normal even in those with severe disease. In this ECG, there is ST segment elevation in AVR and V1 along with ST depression in inferior and lateral leads. ST elevation in AVR more than that in V1 is also suggestive of left main disease. In addition, there is right bundle branch block pattern. In this ECG, ST segment elevation and T wave inversion are present in 2, 3 and AVF, the inferior leads. ST segment is curved and T waves are inverted in V5 and V6, the lateral leads. Minimal ST segment depression is seen in lead 1 and AVL, which can be taken as reciprocal to the ST segment elevation in inferior leads. There are tall R waves in V1 and V2 with R by S ratio more than 1 and ST segment depression with upright T waves. These features are suggestive of posterior wall infarction, being the inverse of Q wave ST elevation and T inversion, which would have been recorded in a posterior lead.